Good evening, everybody. Welcome to our fall conversation. I'm Ellen Maloney, President and COO of Newton-Wellesley Hospital, and I'm just delighted to be with you this evening. Our conversation series is an opportunity to tap into the amazing clinicians we have at Newton-Wellesley and the wonderful care that they provide to our patients. I'm really looking forward to the presentation from our Department of Medicine featuring our chair and 3 wonderful division chiefs. Before I introduce our panel, I'd like to tell you a little bit more about the sponsors of our event this evening. You may have noticed that tonight's program is presented by the Eliza P. Kendall Society, which is Newton-Wellesley's gift planning society. The Eliza P. Kendall Society recognizes and celebrates generous donors who have included Newton-Wellesley in their estate plans, whether through bequests, life income gifts, or other vehicles. These supporters are making a lasting commitment to advancing care right here in our community. As you consider how our hospital fits in your own plans, I certainly hope you'll consider joining the Eliza Kendall Society. Just as your lifetime giving will make a difference, your bequest can extend your influence and live on as a clear message about your personal values and what mattered most to you. So if you've already included Newton-Wellesley in your estate plans, thank you. Please make sure the development office is aware of this so we can recognize and celebrate you. And if you're considering doing so, or if you'd like to learn more about our gift planning programs, please see any of our colleagues from the development office who are here with us this evening. So again, thank you for being here with us tonight and for all of the ways you support our hospital. I hope you will stay after our presentation to enjoy some drinks and bites with us and so that we can get to know you better. I am delighted to introduce the moderator of our panel tonight, Dr. Larry Friedman, Chair of the Department of Medicine, and please join me in welcoming Dr. Friedman.
Well, thank you, Ellen, and good evening. It's great to see so many people here, and I get to talk about my favorite topic, the Department of Medicine at Newton-Wellesley Hospital. This is a screenshot of one of our meetings in which all of the division chiefs and key administrative personnel participate. The Department of Medicine is always the backbone of any hospital. It is. And it's the largest clinical department, and it has a rather complex structure, as you can see here. It's even color-coded because there are people who are in private practice, people who are employed, some people associated with Mass General, and some people who are primary care and others medical specialties. So the details don't matter, but I want you to see the complexity, and perhaps you'll pick out a name or two of someone who has cared for you or that you recognize. Every person on this list, except one, was recruited by me since I came to Newton-Wellesley 20 years ago. Trivia question, who's the one who preceded me? She was supposed to be in the audience. Joanne Borgstein of Physical Medicine and Rehabilitation. You know, she's older than she looks. So this is the growth. This is the growth of the Department of Medicine. We've almost doubled in size. In fact, this year we will more than double in size since I came in 2003, because we're adding many physicians from other Mass General Brigham hospitals who are participating in the home hospital program, in which physicians credential at all of the Mass General Brigham hospitals and provide care at home to patients who might otherwise require hospital admission. We also have recruited many advanced practice providers, or APPs, nurse practitioners and physician assistants, who have become essential in the care of our patients, both inpatient and outpatient. So this is a brief, truncated summary of the highlights of our department, the things that I'm most proud of for the past 20 years. Number one, we have strong divisional leadership. I spend a lot of time finding the right person for each leadership position. And I have 3 case examples right here. These are superb clinicians who love to teach, because I think a teaching environment is good for patient care, and it enhances the quality and safety of the environment. We have a world-class hospitalist service. We have really focused on that, because I recognized 20 years ago that primary care doctors would no longer have the time to visit their patients in the hospital. And we want someone near or at the bedside all the time. And so we recruited hospitalists. We went from 7 hospitalists to now 70 hospitalists. And they cover all of our inpatients. They do consults on other services. I like to say they provide humanitarian aid for orthopedics. They are the cream of the crop, I will tell you that. We have developed our intensive care unit, and we collaborate with Mass General so that emergency medicine and anesthesiology and critical care physicians rotate through our intensive care unit. I would also point out it is the top-rated teaching environment among the Mass General house staff who rotate there. We have developed great teaching programs, because I feel that clinical excellence coincides with great teaching, and I'll tell you a little about them. We have developed strength across the subspecialties of internal medicine, and as you could see, there are a lot of them. We have created a division of palliative care, which has become so important in the care of patients facing terminal disease. We developed a stroke service, and we have all the modern approaches to stroke management. And that's not an easy thing to do, because you have to do it quickly, because time is brain. We have created what I think is the best community hospital cancer center in the United States, in part because of our colleague, Dr. Blaskowski. We're integrated with the Mass General Cancer Center. We now call it the Mass General Cancer Center at Newton-Wellesley Hospital. And we have gone from general oncologists and hematologists to subspecialty-oriented hematologist-oncologists, so that we have people who focus on specific cancers. Under Dr. Filippides' leadership, we have developed the Elfers Cardiovascular Center. There's no cardiac catheterization lab or cardiothoracic surgery at Newton-Wellesley Hospital, because we have the Brigham and Mass General to draw on. But we have everything else, and we do it well, and we have great facilities. And this has been a stunning success. Our diabetes care, under the leadership of Dr. Stepel Resnick, is second to none. And we even have a gestational diabetes clinic. I'm a little partial to endoscopy, because I'm a gastroenterologist. And we have a first-rate endoscopy suite and great endoscopists. And we do a lot of cutting-edge procedures that are not generally done at community hospitals. An interesting development during the COVID pandemic was that we became the #1 funded community hospital in America for COVID clinical trials. We annually get grants now of over $1 million in total, which is really remarkable. In fact, in one study, we were #2 in the country in funding after Vanderbilt. I don't know what they were doing, but that was very impressive. We have great internists. Now, primary care is done by both internists and family medicine, and we have strong groups in both areas. There are about 35 family medicine physicians, and there are about 100 primary care general internists. It's hard to get a general internist now, as you all know. They're very busy, and they're in great demand. But I am convinced that good medicine starts in primary care. And we've been successful because one of my goals was to raise endowments, because I wanted to support our faculty and support the teaching mission, because I think that makes us better. And the community has been very generous in supporting the Department of Medicine. It's also allowed us to have special lectures and recruit visiting professors, who are now virtual visiting professors, from all over the world, as far away as Hong Kong, it turns out, to educate and enlighten us. So here are our teaching affiliations and the groups of people who rotate through Newton-Wellesley Hospital. We have interns and residents in medicine, so it's a 3-year medical residency. We have our own group of interns, and then interns and residents from other Mass General affiliated programs. Mass General itself, the Mass Eye and Ear, McLean Psychiatry, and in physical medicine and rehabilitation, Spaulding Rehabilitation Hospital. We also have medical students, and here our affiliation is primarily with Tufts. It turns out they're very good medical students. The Harvard students, they used to say, study the book, and the Tufts students study the patient. So we're very happy with them. And then we have physician assistant students. We are the official hospital of the Massachusetts College of Pharmacy and Health Sciences, one of the best training sites for physician assistants. So evidence of our academic bent is the number of publications produced each year by the Department of Medicine. And you can see that in the past 4 or 5 years, the number has really gone up. That relates to a number of recruits, affiliations with Mass General, and just the academic environment that has been created. When I first came, there were 55 publications, all by 4 people. And now a lot of people are involved in these pursuits. Each year, we develop goals, and they're based on our values, including culture, clinical excellence, a commitment to growth, clinical integration and collaboration, and community. We're very big on supporting the community. And I've given some examples of the most recent goals. We're always interested in increasing diversity, and our recruiting efforts make sure that everyone has a chance to come to Newton-Wellesley Hospital in whatever capacity. Clinical excellence, which I have to say is my thing, is based on recruiting the best people you can get and developing new services. And this year, we introduced a cutting-edge approach to the study of coronary artery disease. It's called CT, computed tomographic coronary angiography. We can study the coronary vessels without injecting a catheter. And it saves a lot of people other interventions that would be more invasive. In the field of oncology, we now have 2 LINACs. A LINAC is a linear accelerator used to deliver radiation. We may be the only community hospital around that has 2, and they're state-of-the-art. Collaboration is in our blood. We're always collaborating. I sit in on the gastrointestinal oncology conference every week, and we have radiation oncologists, and we have surgeons, we have oncologists, radiologists, and gastroenterologists, and we have very robust discussions in the management of patients. We are developing a cardiometabolic center, which Dr. Stapel-Resnick and Dr. Philippides may mention. And also in cardiology, looking at our community, we saw there was a big unmet need among South Asian patients who have a very high incidence of heart disease at an early age, and we set up a center for them. So I wanted to show off some of our endowments. This is what we've raised over the past 20 years. We endow leadership and teaching positions so that people can carve out a little time. I know this is a mixed message because you want your doctor to always want to see patients, and they do. But they also need a little time to learn and to teach and to interact. And these endowments help greatly. And they facilitate, they don't detract from, they facilitate patient care. And then here are some of the professorships and lectureships that we have developed. Now, there's no shortage of challenges. I don't want to whitewash all this. We have many challenges. That's where Ellen comes in, and because we all complain to her about this. We're victims of our own success. We have more patients than ever, and they're sicker than ever because people want to come to Newton-Wellesley Hospital. And the academic centers like Mass General and the Brigham want to transfer their patients to Newton-Wellesley Hospital. So we're busy. So access has become a problem, and it's a particularly acute problem in primary care. We are overloaded with patients, and that creates workforce issues. And there aren't many people going into primary care anymore as there used to be, so it's very hard to recruit. We need support for our practices, and that includes not only physicians, but ancillary personnel, APPs that I talked about before. We always need more space. We always outgrow whatever new space we have. We are trying to provide services on weekends that we never did before, and that creates challenges, but we've made headway, for example, in cardiology, which now sees patients on the weekends. And we're always facing the challenge of burnout. People are working harder and faster and had the stress of the pandemic and budgetary limitations. And so there's a high rate of burnout among physicians. But we like working with each other, and that sustains us. The cost of living in Boston is high. It's hard to recruit. People are under financial stress. There's a medical record system that I'm sure you've all heard about, Epic. And it's great because we can communicate with each other, but it seems to have one of everything. And the complexity of it and the number of messages and the data that has to be processed by a physician is enormous. And so many of our docs go home at night and spend another 3 or 4 hours going through their Epic in-basket. The house staff have recently unionized. We don't know what effect that will have, but they had their own grievances. And then we have to work out our relationship with Mass General Brigham because we're part of a network now. We want to retain our individual identity, but we also recognize the value of being affiliated with some of the greatest institutions in the world. So over time, we're going to have to reimagine our models of care, and this will be a work in progress for a while. So assets of the Department of Medicine: we have thriving clinical services, we have robust training and teaching programs, we have progress in advancing equity, we have a solid academic productivity and clinical research presence, and we are an important component of the MGB, Mass General Brigham Network. When I first came out here, Jerry Austin said to me, he was the head of cardiothoracic surgery at MGH and one of the leaders of Mass General Brigham when it was partners. He said, "We will now have to rethink our Western strategy." We have great people, and we like Newton-Wellesley Hospital. It's a great place to work. Of the 112 physicians who were named top doctors in Boston this year, 56 were from the Department of Medicine, over half. So a little about me. This is my background. I actually started at Princeton, but got into an accelerated program at Johns Hopkins, where I stayed on for residency in medicine. I then came to Mass General to do my fellowship in gastroenterology. I was recruited then by my mentor from Hopkins to Jefferson in Philadelphia, where doors were opened for me, and I became the House Staff and Fellowship Program Director and the Vice Chair of the Department of Medicine. I was then recruited back to Mass General. That doesn't happen very often. I thought maybe a mistake had been made, but I was recruited back. I became a director of the Fellows Clinic and had a major teaching position with the House Staff. And then I was on the committee that developed the affiliation between Mass General and Newton-Wellesley Hospital, and I was so impressed with the place that I applied to be chair of medicine, and I got the job. And as part of that job, I'm also assistant chief of medicine at Mass General, and I have academic appointments at both Harvard and Tufts, which is interesting. I am a clinician educator, sort of a classic. These are some of my contributions, and I would call this my hobby. So I'm going to introduce today's speakers. They're probably concerned that I spoke too long, and they probably will too. But they're worth listening to. We have done some great things. So first up will be George Philippides, the chief of the Division of Cardiology. He's also serving as our interim director of our medical group, and he's the president of the medical staff. And he's a very busy guy. Jean Stapel-Resnick, who is a master diabetologist. She has introduced some of the cutting-edge technologies in diabetes and has run the gestational diabetes clinic and directs diabetes care. And Lawrence Blaskowski, who was my favorite oncologist before I got this job, when he was at Tufts and I was at Mass General, and then he came to Mass General when I came to Newton-Wellesley Hospital, but I discovered that he is like the world's expert on liver cancer, and I've always used him as my preferred oncologist. He's the medical director of the Mass General Cancer Center at Newton-Wellesley. So with that, I will turn the program over to Dr. Philippides.
Thank you, Larry. Good evening, everybody. Let me see if I got the button right. So when your CV is not as strong as Larry Friedman's, what you do is you throw in pictures to distract. So I'm now going to begin my bio sketch with a series of pictures. So my family from generations is from I'm distracting, is from this little island shown in the bottom right. It's that long green island between Crete and Rhodes. It's called Carpathos. It's a gorgeous island in the Mediterranean, and it's dotted with beaches that look like that. There are like 20 to 30 of them, okay? And this is actually the beach where my dad and my uncle taught me how to swim when I was a little kid. We used to go back quite a lot when I was younger. So my parents, just before I was born, moved to a different Long Island, this one, here outside of New York. And I was born just barely and raised initially in Brooklyn, New York, before You can relate, Larry. Before I moved out to the island to a place called Garden City, New York, in Nassau County. And Larry, do you know what Garden City is known for, what it's famous for? Larry's good at trivia. Roosevelt Field was the airway where Lindbergh took off for his historic flight, about 200 yards from where my house was. Right? So that's what we're famous for. And then I moved to the other side of the Long Island Sound to Yale University, where I went to college, back to New York for medical school at Albert Einstein College of Medicine. I didn't really travel much. I kind of stayed in a little area. And then finally, I took the long trip up 95 to Boston, where I did my internship, my residency, and my cardiology fellowship at Boston Medical Center, then Boston City Hospital. I stayed on staff there for about 20 years, aging myself in the coronary care unit and in the cath lab. And in 2014, had the really good luck to meet Ellen Maloney and Larry Friedman, and they gave me the dream job of coming to Newton-Wellesley Hospital, where I became the chief of the division, and I also serve, as Larry had mentioned, as the medical director for the Elfers Center, president of the medical staff, and an interim director of the medical group. It's been a busy year. And again, having just a great time, the best thing that I ever did. So that's sort of been my path here. Most importantly, I'm married to Leonore, shown here, who's a primary care physician at the BI. We have 2 sons, John and Alejandro, and the best dog in the world, Amanda. Somebody once told me, if you want to get good evaluations on your talk, show a picture of your kids and your dog. So when you get the evaluation sheet, please remember this slide, okay? Because the rest of the talk I don't think is so good. All right, so now I'm going to talk fast. Remember, I'm from New York, and I'm going to go really quickly through the cardiology division, not because it's not important or fascinating, of course it is, but I think you guys sort of know a lot of this. So we have very, very busy outpatient clinics, as many of you know. We have one in Newton-Wellesley Hospital, Needham, Wellesley, and a new one in Chestnut Hill, and they're all terrific. We also, as Larry had alluded, have some subspecialty clinics embedded in our general clinics. So we team up with the stroke neurologists. They see their stroke patients once they're discharged in our clinic, because we understand that stroke patients have vascular disease, and oftentimes the reason for their strokes are cardiovascular disease. So we see them in tandem or in series to make sure that it's really easy for the patients and they get good care. That sounds basic, but a lot of other hospitals, you'll see one and then wait for months to see the other, and they don't talk. We basically are working side by side. We have a robust prevention and cholesterol clinic, a lipid clinic. And this is for patients who don't have vascular disease, but they might have strong risk factors, a strong family history that's concerning, really bad cholesterol, or questions about the risk factors. And we'll see them do whatever testing they need, and then help get them the kind of the counseling they need for a heart-healthy life. I'm saving 2, the ones with asterisks of our clinics, toward the end, because they asked us to sort of finish with innovations. And as Larry alluded, we have 2, I think, very innovative clinics embedded within our clinics, the South Asian Clinic and our Newton-Wellesley Hospital MGH Arrhythmia Clinic, which I think is fantastic. Within the second floor, the cardiovascular world, we have a device clinic, the Briazano Device Clinic, which is where our patients with pacemakers and defibrillators and other what we call implantable cardiac devices go to get taken care of and have their devices checked and make sure that they're doing well. We also, right next to our clinic, have a fairly large and thriving non-invasive lab. That's where you go for cardiac procedures that doesn't require a needle. So things like stress tests and echoes and monitors and nuclear stress tests, the whole array of what we call non-invasive testing that's very, very busy and quite high quality. And then, as you might imagine, we have a team of cardiology consultants who see patients in the hospital, in the ICU, in the emergency department, and sort of help manage them along with the excellent hospital service and excellent ED and ICU that we have. And that's really busy. And it's staffed, for the most part, by these 4 women shown here, are PAs. So we really work very closely in teams of doctors and PAs. We're sort of big believers in that team approach. And then finally, as Larry said, we have a state-of-the-art cardiovascular center, the Elfers Cardiovascular Center, and that's one of the rooms. And you can see it looks like something out of Star Trek. Clinicians who come from the general and other hospitals and do procedures here just cannot wait to do more procedures here. They say that the equipment, the visualization, the fluoroscopy is better than any place around. We share this space right now with vascular surgery, who does major arterial procedures there, with a very busy interventional radiology division, who do lots of procedures there, And the procedures that we do in this center, I show here on the left side, lots of them, including putting a lot of pacemakers and defibrillators in. Okay, so that's sort of the realm of procedures for now. I'm going to talk about the last two a little bit later. We also don't focus on the people who are acutely ill. We very strongly lean into prevention and cardiac rehabilitation. We have a fantastic cardiac rehab program at Newton-Wellesley Hospital focused on patients who recently had a heart attack or been admitted for major cardiac procedures like bypass or valve procedures. This is a multidisciplinary group of nurses, therapists, nutrition specialists, exercise specialists who then get patients back to heart health. If you look at the picture shown there and then look at the second row of the aisle here, you'll see a remarkable resemblance, because this is part of the cardiac rehab team and also part of the team, we all work together, of a lot of our community outreach. So at Newton-Wellesley Hospital, we have a great Heart Health and Wellness Council that's part of our community outreach efforts, led by Beth Keene and Jane and John, who are here with us today. And we all work together to make the Newton-Wellesley Hospital community more heart healthy. What we have focused on over the last couple of years, we focused on a lot of things, but I think the two big wins, you guys might agree, is that we have focused on getting older people out of the house and more physically active by way of making their hearts healthier and their souls healthier. We all know about loneliness and social isolation in old folks that got really exacerbated during COVID. So Jane and others have done a lot of work in getting people to walking groups where we'll often join them and do sort of a walk with the doc kind of program. We've partnered with the JCC and different colleges around to get that going, and that's been a huge success. And the other huge success has been our firefighter program. How many of you guys have heard about the firefighter program? Good. You're going to hear about it again. So we have gone to many firehouses in our greater community, especially in Newton and Waltham, and give sort of a crash course, a 3 to 4 part course on how to be heart healthy. Why is this important? By far and away, the #1 killer of firefighters is cardiovascular disease, and a lot of them, how shall I say, are young men with not the best cardiac lifestyle. So we go in and talk about risk factors in general. We give demonstrations on diet and things that they can cook in a heart-healthy way. We give them teaching on physical activity and relaxation, and it's been very, very well received, and we've been now asked back to sort of do this again on a regular basis, so we're really proud of those efforts. And then finally, before I get into innovation, you should know that Newton-Wellesley Hospital has been recognized by the American Heart Association as a center of excellence for atrial fibrillation care, heart failure care, and stroke, 3 of the really sort of big issues in the cardiovascular world. And I think, Larry, correct me if I'm wrong, we're the only hospital to have gotten all 3 of those for 3 or more years in a row. So it's a really great team that we get to work with, and for a community hospital, I think that the clinical services are robust and quite good. All right, I'm now going to shift gears and talk slower about 3 or 4 what I think are innovative programs at Newton-Wellesley Hospital. And again, Larry sort of mentioned one. Lots of studies over the last 20 years have shown that people of South Asian descent, India, Pakistan, and those regions, have much, much higher levels of diabetes, as Jean will certainly attest, and higher levels of heart attack and stroke, despite the fact that they're much more likely to be vegetarian, not smoke, and be a lot slimmer than the average American. There are lots of metabolic reasons for that, but it's been underappreciated, underdiagnosed, and undertreated for a long time. And as a result, these patients tend to develop these issues at much, much younger ages. So after a collaboration and conversation with Ami Bhatt, shown on the bottom right, who's a cardiologist at Mass General Hospital, we decided to put together a multidisciplinary crew here at Newton-Wellesley Hospital focused on these patients. And it basically features the 3 Newton-Wellesley Hospital cardiologists shown on top, in conjunction with a fantastic nutritionist, Mitali Bixby, who speaks 3 or 4 dialects out of the India subcontinent and who's very well versed in cardiac diet, but also South Asian diets. So the way that this works is patients go and see the cardiologist. They then will have time to see the nutritionist with their family for a full hour, and when appropriate, see Daniel Destin, who many of you know is the director of our excellent Shipley Fitness Center, where they get customized exercise prescription. Again, a really amazing cutting-edge program, and I think it's one of only 3 in the country, and the only one, I believe, that is east of the Mississippi. So we're really sort of proud of this program. Oh, and I should mention that all of the innovations I'm about to talk to you about really are under the sub-theme of collaboration and innovation. So in every one of these programs, you'll see how it worked, because not that George or the team at Newton-Wellesley was solely, brilliant. It's because we partner with other people within our system that sort of made it go. And so this is an example of working with MGH and Dr. Bott. The other program that I think is really cool is the NWH BWH dyspnea program. What's dyspnea? It's a medical way of saying shortness of breath. So a fairly large portion of the patients that come into us have shortness of breath, and it's not understood why they do, or fatigue, despite the fact that they've gotten lots of cardiac tests and lots of lung tests. This is a really common scenario. And our pulmonary colleagues, Drs. Waxman and Stump at the Brigham, have a special program and a test called a cardiopulmonary exercise test that actually can help diagnose what the reason is for the shortness of breath or for the fatigue. And they have brought that technology and that clinic over to us at Newton-Wellesley Hospital in the Elfhurst Cardiovascular Center. And I'll give you a quick sort of exposure as to what it is. Patients who have fatigue and shortness of breath that are not explained will go into our procedural area, and then, shown out here bottom left, and they'll have this catheter, this yellow catheter shown on the bottom, placed into a vein here in their neck and then into their hearts. And while the catheter is there, we measure oxygen and pressures and anything that we can measure to sort of see what's going on with the heart and the lungs. We then tape the catheter in, literally, put them in a stretcher, and roll them 50 yards down the hall into our non-invasive lab, where we put them on a bicycle and have them do a really hard stress test. We bike them really hard while we're measuring the oxygen they're sucking in, the carbon dioxide they're breathing out through a mask, and all the pressure. You're making a funny face. Is this okay? It is pretty cool. And then the pressures and the oxygenation in their heart. And by getting this incredibly precise physiologic information, by the end of it, in a large proportion of cases, we can say, was the problem the heart? Was it the lungs? Is it a muscle problem? Is it a neurologic problem? Are they not trying? Or is it something that might have to do with long COVID? There's actually a pattern in long COVID of having some muscle issues and vessel issues that we have picked up with this test. So with a sizable population of folks who were really debilitated by shortness of breath and fatigue, they're now sort of leaving this cutting-edge program with a better understanding of why they're so limited, and oftentimes with sort of new therapeutics to make them feel better. Okay, so again, collaboration and innovation. We did this in conjunction with Brigham and Women's Hospital, and it's been a huge success. The next one to talk about, again, collaboration and innovation, is our Newton-Wellesley Hospital MGH arrhythmia program. So the first weekend that I was on call back in 2014, 16 of the 18 patients that I saw that weekend had atrial fibrillation, an irregular heart rhythm. And it became pretty apparent to us that we were going to be seeing a lot of rhythm problems at Newton-Wellesley. So we teamed up with two arrhythmia specialists from the General, Dr. Musa Mansour and Leon Ptacek, and created kind of a one-stop shopping multidisciplinary clinic. So the schema is you come in and you see one of our cardiologists, shown on the left, Dr. Parpos and Coronado. They then, if they feel that you need pharmacologic therapy or a procedure in the Elfhurst Center, a cardioversion or a pacemaker, will proceed with the aid of these two MGH arrhythmia physicians. But if they need to go on rapidly to a procedure like an ablation at Mass General Hospital, that's arranged right on the spot after a conference of these physicians and nurses. Aftercare is taken care of by a nurse practitioner and a clinical pharmacist who focuses on the very complicated medicines and blood thinners that these patients use. Now, this sounds simple, but in generally 1 or 2 visits with a conversation between this group all collaborating, that's the theme, amazing therapeutics sort of get done with really complicated patients, okay? Again, I know of very few other community hospitals that have this kind of system put together. And what we're hoping moving forward is one of the high-level procedures, that ablation procedure I told you about that you have to go into Mass General. There have been some advances there, and we're thinking or hoping maybe that can come to Newton-Wellesley someday. Larry mentioned the incredible CT angiograph machine that we have that allows you to forego a stress test and forego an invasive procedure where somebody has to put a catheter in your vessel and snake it into your heart. Instead, by just going through a simple CAT scanner, like you can see on the bottom right, we get these incredible outlines of the coronary arteries, and that can help us, within a matter of minutes, know if somebody can be discharged from the emergency room or if they need to go directly into town to have their vessel opened. It has been a real game changer at Newton-Wellesley Hospital, and we're using it a lot. It's been great. And then finally, I'm going to end up by 2 things that don't sound innovative, but actually really are, and that is the relationships that we are building within the different Mass General hospitals and also between the different Newton-Wellesley hospital divisions, okay? Again, innovation through collaboration. So here's Newton-Wellesley Hospital all by its lonesome, okay? For a while, we have benefited greatly, for many years, of having incredible collaboration and access to Mass General and the Brigham. It has mostly in the past, not now, taken the form of us sending patients to them, bypass operations, high-level procedures. But more and more, certainly since I've been here, there's a two-way movement of talent, and such that a lot of the clinicians there are now part of our staff and work with us. They're embedded in our programs, such that we can offer academic medical center care here at Newton-Wellesley. But there's a new thing on the horizon that you might have heard about it, which is Mass General Brigham has been focusing on coordinating not just a few hospitals near the city, but all the hospitals and the clinics in the greater Mass General Brigham community. We've actually created something called the Community Division. So all the hospitals and clinics, essentially, that are not Mass General and Brigham now meet on a weekly basis. I'm part of those meetings to talk about how we can work together, share resources, and we even send patients back and forth from community hospitals when we have a resource, say the dyspnea program, that another hospital might not have. And this has really upped the game because now I not only have the menu from those two places, I have a full array of resources to offer my patients, and they can get it in the friendly confines of Newton-Wellesley Hospital. So this has been a game changer, and it's only going to get better. Finally, we, Heart in the Center, have been doing, I think, a slow but much better job of reaching out and working with our colleagues in the other divisions. And I think Dr. Blaskowski and Jean are perfect examples to understand that, you know, our patients are their patients are our patients. So Jean and I have been working, and we're going to make this happen, of trying to get a system together whereby all of these very complicated, expensive medicines that our patients should be on, that we actually work together. Our nurse practitioners work together, our doctors work together, the pharmacists do, to create a seamless system. So that for the patient, it's not that I've got to go to this clinic and that clinic. I go to one, they're all talking to each other, and it's much easier for the patient. So that we've been working on that. And similarly, in Larry's role, I don't know if you're going to talk about this, Larry, there's a whole new field called cardio-oncology. Larry is saving so many patients with the new chemos and immunomodulators that they're surviving, but they're having heart problems, sometimes because of the cancer, sometimes because of the medicines. And so you need collaborative people who work together side by side to take care of those patients. Stroke, we mentioned, that's an obvious one, okay? So I think the next cutting edge of innovation, believe it or not, is not going to be any new technology, although we need that too. It's going to be ways that we break down artificial silos, and the three people here on this stage work sort of seamlessly. So I want to sort of leave us on that kumbaya moment. Thank you for your attention, and I'll be happy to take some easy questions over a drink later. Thank you.
Thanks, George. That was a nice lead off into me speaking with you, and I'm really glad to see so many of you here tonight. As has been mentioned many times, I'm the chief of the Division of Endocrinology and Diabetes. And in case you're not familiar with what endocrinology is, it's the field that focuses on hormones and the glands that produce them. And so that means we look at conditions like diabetes and thyroid disease, osteoporosis, infertility, the cholesterol and high blood pressure, with our cardiologist friends, obesity, and many other disorders. And this is our division at Newton-Wellesley, a wonderful array of doctors and nurse practitioners. We have teaching nurses, we have dietitians, and we spend our time both seeing consults both in patients in the hospital as well as in our outpatient clinics. As you've heard before, we have a couple specialty clinics. So I do participate in and run a gestational diabetes clinic that actually, just as an aside, works closely with Georgia's South Asian heart prevention clinic, since they often first show up in a gestational diabetes clinic. And so we have a nice step relationship to once they've delivered, 6 months later, they're getting hooked in with that South Asian prevention clinic. We also have a American Diabetes Association certified self-management education program, which involves classes and working with diabetes educators and dietitians on how to manage diabetes at home. And we also have a thyroid nodule biopsy clinic. So I thought I'd tell you a little bit about how I ended up, particularly in diabetes. And so first I'd like you to take a look at that picture on the right. That's a picture of my mother and my brother, and the slightly befuddled little girl there is me, celebrating my first birthday. And the reason why I show you this picture is because all of us have really been impacted by diabetes in our lives. So my mother was diagnosed with diabetes at age 9. This was only about 35 years after the discovery of insulin. So that saved her life, but it was still an extremely difficult disease to deal with at that time. She had no way of knowing what her blood sugars were at home. There were no ways to check your blood through a finger stick. There were no continuous glucose monitors. There were no disposable needles or syringes. She had to use glass syringes. She had to sharpen her own needles. It was a really difficult disease to live with, and it was a daily up and down battle. So this was what I saw from my earliest years. And so from a fairly early age, I had decided I was going to be a doctor and I was going to take care of diabetes patients. And so I went to college at Emory University and I worked my way up the East Coast. I don't have the maps, but you can imagine. I went to Johns Hopkins for medical school and then went to Yale New Haven Hospital for my internal medicine residency, and finally landed in Boston, where I've been ever since. I did do my fellowship at the Joslin Diabetes Center and the BI, and once I was done there, I came over to Mass General in Newton-Wellesley. But after a few years, I realized that really community hospital medicine was where my heart was. And so I brought all my clinics over to Newton-Wellesley, and I've been here ever since. And so during that time, I've been director of diabetes care and more recently the chief of the division. Now, unfortunately, during this time, my brother also received the diagnosis that he had diabetes that required insulin. And he and I often nowadays talk about the amazing strides that have been made in diabetes technology, so that he can use a continuous glucose monitor. He can know what his blood sugar is literally every minute of the day if he wants to know. He can use an insulin pump that communicates to that continuous glucose monitor. He can use a smartphone, which nobody could even imagine back in 1955, right, to help with all of this management. Now, that is not to say, and anybody in the audience who has diabetes will agree with this, it is not an easy disease just because we have technology, but it's much easier to manage the day-to-day ups and downs, and it allows people to live their lives more fully and have a better quality of life for sure. So just as there has been enormous strides in technology over the years, what I'd really like to focus my talk on now is the way that we think about diabetes, particularly in regards to type 2 diabetes. And I think you'll see the connections with George's talk as I go through this. What we have learned over the last, I would say, decade or so, and every year we learn more about this, is that type 2 diabetes is intimately connected to other organs in the body, in particular connected to cardiovascular disease, chronic kidney disease, and liver disease. And patients that have type 2 diabetes are at high risk of having one of these others, and vice versa. And the risk factors are the same for those. And so this phenomenon has actually been given a name, cardiometabolic disease, and so you'll hear that. And even in the lay press just recently, I think the American Heart Association just came out with this cardiology, kidney metabolic disease, just rolls right off the tongue. But you will start to see this and in the regular press as well. But for today, I'm just going to call it cardiometabolic disease. And so one of the things that has been really revolutionary is that some new classes of drugs that were developed over the last decade, maybe 2 decades, they were developed purely to help control blood sugars. They were meant to be diabetes drugs. And they worked, so we started using them. And then study after study after study showed that there was more benefit to these drugs than just lowering blood sugars. There was a reduction in cardiac events, so lower rate of heart attacks, lower rates of hospitalizations for congestive heart failure, decreased rates of stroke, delayed progression of kidney disease to end-stage kidney disease or dialysis, and even improvements in survival and lowering of death rates, both from cardiac causes and from all causes. Well, this is amazing. I mean, in diabetes, we don't really get such good news all the time. This was fantastic. And so this has really changed, has really caused a paradigm shift among all the societies in terms of what guidelines they're recommending at this point. So the American Diabetes Association, the American Cardiology Heart Association, the various cardiology societies, the kidney societies, have all in the last few years been redoing their guidelines to focus on this cardiometabolic disease. So as an endocrinologist, as somebody who really always was first and foremost looking at controlling the blood sugars, all of a sudden now, I'm not just looking at the blood sugars, I'm also making sure they're on their cholesterol and their blood pressure medications. And we really are starting to think about these newer medications that provide that heart and kidney benefit. Unfortunately, on average, it takes 17 years to go from scientific evidence to clinical practice. 17 years. That's a lot of patients being impacted by that. And in fact, it's being given a term, clinical inertia. And it definitely is real in cardiometabolic disease. So this is one study that looked at a large number of patients, over 150,000 patients. They all had the same health insurance. They were at different centers. And it looked at patients with type 2 diabetes and heart disease and wanted to see how many of them were taking what we call a medication bundle, 3 medications in the study that were recommended to treat cholesterol, blood pressure, and that heart and kidney risk. And amazingly, only 2.7% were on all 3 medications. And over a third of the patients were on none of these medications. Really shocking. And so in the field, we started looking into why is clinical inertia coming about? Well, you know, I think everybody is a little bit to blame, but everybody's also trying their best, and that has to be understood. So patients may not understand the ramifications if they're not on these medications. They may be scared of side effects, and anybody who has diabetes or knows somebody who has diabetes, you understand that they are not only on a lot of medications, but they are very expensive medications. And that can be really difficult, particularly as economic times get tough. It's really hard to get on even more medications than they're already on. Physicians are well-meaning, but very busy. And so it can be hard to keep up with the guidelines. They also, in the spirit of do no harm, are often too conservative and don't adopt guidelines early enough. There's also not necessarily clear evidence on how to personalize the treatment to each individual patient. So out of concern for not hurting the patient, they hold off on that. And really, the healthcare system itself is not really built for this type of teamwork. It takes major effort and with trying to collaborate, but even so, there are lots of hurdles that get in the way. The system is built in such a way that a patient sees a primary care doctor and may have a specialist, one of which will give a few of the medications, but they're not seeing the other specialists that might be taking care of those other organs. So many, many patients are on a few of this recommended guideline bundle, but they're not on all of them. And being on all of them is really what gives us those great rewards. So what's been mentioned before and what seems to work is something called a cardiometabolic clinic. So that one-stop shopping idea where a patient comes in, sees a host of clinicians and assistants and staff members like behavioral psychologists and dietitians and the exercise physiologists, and works on lifestyle modification like exercise and smoking cessation, has access to the specialist as needed. But one of the key players is actually the clinical pharmacist who can help optimize that medication regimen and really work on the cost savings, because that is one of the big stumbling blocks. So I'd like to tell you about a center that's out in Kansas City that has had really amazing results in working on a cardiometabolic clinic. So they created what they called a cardiometabolic clinic center of excellence, and it was based on this model of having the patient come in. There was a nurse navigator that comes and makes sure that the patient is seeing all the people that they need to see, really focusing on making sure that they have access to the specialists as needed. They have, as well, a clinical pharmacist to help with those medication regimens, and then other specialists as needed, like eye doctors and obesity specialists and foot doctors. And they had tremendous success with this. And so they decided to turn this into a program and take it on the road. And so they have now created what is called a Cardiometabolic Center Cardiometabolic Center Alliance, CMCA. And they have 20 centers at this point where they have brought their program to it and been able to have really remarkable effects. And so I'd like to just show you some of their results not just at their center, but at these other centers. And I will tell you that the hospital centers that they included were community hospitals, they were academic hospitals, and they were rural, they were urban. I will say that when they come to community hospitals, it seems to be a little faster, a little easier, if you ask them on that. But they were able to have success really everywhere. And this takes a look at 6 of their first centers. Now, they looked at patients with diabetes and heart disease, and they started with a baseline of 28% on, at this point, the guidelines were now a 4-medication regimen. A 4-medication bundle. And you may wonder, well, how were they able to get to 28% if the study I showed you before, they couldn't even get to 3%? Keep in mind that the centers that joined this alliance are already working hard to get patients on these medications. They're doing the best they can, and they're not able to get above a 28%. Now, they were able to double the percentage, more than double, the percentage of patients that were taking all 4 of those medications that were recommended by guidelines within 6 months. They had a massive change. And then they looked at, well, what about for diabetes and chronic kidney disease? And they had almost identical response. So what is special about this group? What is it that they've done that is so hard for other people and for other centers? The best thing that they do, well, there's a couple things. One is that they come out to each center that becomes a member of the Cardiometabolic Center Alliance, and they personalize within the framework of that hospital center. They're not reinventing the wheel each time, but they work within the structure that's already there. They have a tremendous web-based library of educational materials for the patients, as well as for the clinicians and for the staff there, so that clinicians can easily keep up to date with the guidelines, because as you can see, every year there's another set of guidelines. These are changing over time. So they have access to those. They also have guidance on how to individualize the guidelines, so that it is able to be applied to each patient that comes through the clinic. And perhaps best of all is that they maintain a registry that each member center is able to communicate back and forth with them with de-identified information, so they don't have the names of the patients, but they keep a registry of the patients involved in the clinic, and in real time they return back to the clinic to tell them which patients are not up to guideline care. And that's how they're able to do it so rapidly. They're able to jump on it immediately in ways that we are just not set up to do in the way that hospital centers are structured usually. So why have I told you about this? Well, let me tell you. I really want you to understand, first and foremost, that cardiometabolic disease is something you should know about. It's a huge public health threat, and it may influence people, either yourself or your family and friends. So you should know about it. And you should also know that there's been this big paradigm shift in the guidelines, because there's such a clear impact on clinical events, on hospitalizations, and even survival. A lot of these therapies, unfortunately, are not being used even in these very high-risk patients. And so ideally, I would like us to become a member of the Cardiometabolic Center Alliance so that they can come out to help maximize the benefit that we can give to our patients in the same way that they've done with theirs. Unfortunately, this takes resources, and hopefully that's where you come in. So with that, I will hand it over to Larry.
Okay. Well, thank you all for coming tonight. I guess I'm the one who closes up this, so try and keep you awake. All right, so I figured I'd start with my journey. Just like George, born in Brooklyn. I didn't know you were born in Brooklyn. But we learned very, very quickly when I got here that he was from Garden City, and I grew up in this funny town called Hicksville. And, you know, when you grow up in Hicksville, everybody knows Hicksville's hip. It's the largest unincorporated village in the United States. It's where Billy Joel came from. But when you then come up to Massachusetts for college and you tell them you're from Hicksville, they're like, you grew up on a farm? You know? I was like, no. I used to live on a potato farm because that's what it used to be, but no. So anyway, I went to Clark University, and everybody in Hicksville said, what in the world is that? Why are you going there? And primary reason was they had a high acceptance rate to medical school. But when I landed there, the people I met, I felt like these are my people. I mean, I just felt comfortable. And I learned from there that every decision I have made throughout my whole life, it's not just a matter of, you know, what's the ranking and what's, you know, who says I should go there. I like to meet the people and feel comfortable because in the end, that's the most important thing. And so I keep telling my daughter, who when she was applying to college, she's like, oh, but yeah, they have a 20% acceptance rate. They're not good. I'm like, forget about that stuff. You have to be comfortable in that. So, and I think that transcends how I like to run our group, that I want to work with people who we enjoy working together with. Because in the end, the patient feels that. So then, I was eager to leave Long Island, and but I knew that I really wanted to go to a state school because I didn't want to come out owing hundreds of thousands of dollars. And I was fortunate enough to be able to go to SUNY Upstate Medical University. And though not a ton of research was being done there at the time, my clinical experience was phenomenal. So when I got to residency in New York City, Mount Sinai, kind of like you were mentioning, the Harvard students, they know the book, and the tough students, they know the patient. I started out at the Bronx VA on my first rotation in the CCU. That was the very first day. Met my first AIDS patient back then, and this was back in 1990. So it was 1990. And people's IVs would fall out. Well, we were in the VA. We didn't have IV teams. So who did they call to put in the IVs? It was me. So I was out there like, I'll put this one in. And really, we had a lot of exposure to patients, a lot of responsibilities. People were watching us. And so that's where I kind of learned my love of actually taking care of patients. I'm very interested in the academic aspects of things and research, but being together with the patient is number one for me. So went to Mount Sinai, figured I would try New York again. And while I was there for just those 3 years, my apartment got burglarized. And one weekend I had my car, I lived on East 95th Street. I had my car 2 blocks away with the club on it, if you remember what the club was. Was going to go visit my girlfriend for the weekend, go up to upstate New York, and where'd my car go? And went to the police station. They said, it's probably on a boat to Ecuador or Belize. And that's when I said, okay, I am done with New York. I gave it a shot. Sorry. So I then came back to Massachusetts because I really love New England. And I picked New England Medical Center because of some of my mentors in medical school who had done their residency and fellowships there. And I was primarily interested in hematology. I really love coagulation, and that's what I thought I wanted to be. I love looking at under the microscope at pathology, and got there, did my research in clotting disorders, and while I was there, the GI oncologist left, and they said, "Larry, do you mind like helping out in the GI Cancer Center?" I said, "No, sure, why not?" And then a few months later, the thoracic oncologist left. They said, "Larry, do you mind helping the surgeon, Ben Daly, who's a very senior surgeon and one of the best physicians I've ever met? Can you come in and work with Ben because he just kicked out the other guy?" And I said, "Sure, I'll do that." So I then stayed there for after fellowship for 7 years, and I did thoracic oncology, GI oncology, and ran the hemophilia center and coagulation disorders. And then in 2003, I started, actually for a few years, I was getting called by MGH. Say, "Why don't you come over here and look at a job?" And I'm like, "I'm not going to the dark side." You know, at Tufts, you know, we all love each other here, and we care about patients. We're not thinking about research, and I figured I wouldn't be happy anywhere else. And so eventually I realized that I wanted to step up my game, potentially be more academic. And it was such a great decision going to MGH. And but they said I have to give up thoracic and I have to give up all the hematology. And so I focused on GI. And I thought they were gonna like help me develop a research program. And I had a few clinical trials, and I was very collaborative with a lot of people. But what they really need is they need help seeing patients. And so some of my colleagues like, "Yeah, you want to see this patient on the floor?" I'm like, "Oh, absolutely." And so I got the reputation of never saying no. And within like a few months, I was already pretty much the go-to guy for GI oncology at MGH, and loved it, and got to know so many people throughout the system. And then was able to, just through taking care of patients and collaboration, and that's one of the things I love about what I do. You can't do GI oncology without collaborating with people like Larry, you know, sharing patients and radiologists, everything. I'll have a slide on that. But then I was asked to be the director of the infusion center, which is like a 65 chair infusion center at MGH, and then ultimately the clinical director of the GI Cancer Center. And we had, I think, 9 or 10 of us GI oncologists, and it was great. I love the people I work with there. And so in 2016, there was a decision to have Mass General take over the cancer program at Newton-Wellesley. And I didn't mention this, but many, many years prior, when I was still at Tufts, one of the members of the practice, actually a couple of members of the practice at Newton-Wellesley, used to send me their coagulation patients because coagulation is like a hot potato. You don't want, it's like liability, and I loved that when I was over at Tufts, and so I took care of those patients, and they're like, "Oh, could you cover us on the weekend?" So I actually covered that practice for quite a number of years. And I still remember going out to dinner with Jeff Wish and Tim O'Connor, and like, "We are in the premier practice. Why don't you join us?" And I was like, "Wow, pretty tempting." But, you know, I really loved the academic practice that I was in at the time. So during my moonlighting, I got a taste of what Newton-Wellesley was. And I knew it wasn't just a private practice or a community hospital. It was really an academic, I felt like a kind of a unique hybrid type situation. And meanwhile, I moved to Needham, so I'm passing there on the way to work. And I'm like, you know, I can't leave Boston until 8 o'clock, otherwise I'm going to sit in an hour of traffic. And I'm like, what if I went to Newton-Wellesley? I could be home in 10 minutes. And I think Larry probably had something to do with me coming out. And I know there was a bunch of back and forth about things, but I said, I will come out if I can recreate MGH at Newton-Wellesley. By that, I mean the best of MGH at Newton-Wellesley. People who know me and people who know people who I take care of, I get very involved with my patients, and that's what I set the standard in my clinic. And I didn't want to change that. I was able to do that at MGH. I wanted to do it at Newton-Wellesley. And, but I wanted everybody to be subspecialized. I was not going to go back to being a generalist. And they said, okay, you could do that. And that's what we developed. And I think we've developed an amazing program in our cancer center on many levels. I mean, I guess another thing, looking at it, when you're at a place like Newton-Wellesley, I know things were in a certain way for a long time, and here you have kind of big old MGH coming, and what are they going to do? Are they going to take over? And I think Larry knew by working with me, I'm very collaborative and very passionate about what I do. And I thought the culture at Newton-Wellesley was great, and I didn't want to change that. But I thought that there were things that can be changed to improve the management of our cancer patients. And I like to have the latest and access to the best. So as part of the cancer center, we don't only take care of cancer, we take care of hematology. It's critically important for our hospital to have a good hematology service. And in hematology, we often talk about benign hematology. The new name for it is classical hematology. And those are things like anemia, bleeding, clotting disorders, iron issues, and something called myeloproliferative disorders where you have very high red counts or very high platelet counts. And then there's a true malignant hematology that we all know of: leukemia, lymphoma, multiple myeloma, and myelodysplastic syndromes. Oncology, I'm sure everybody in this room in some way is touched by cancer. We know somebody who had cancer or passed away from cancer, or maybe have cancer or had cancer. In the United States this year, there'll be about 1.9 million new cases of cancer diagnosed, over 600,000 deaths. And in the Commonwealth, there'll be 42,000 plus new cases, almost 43,000 new cases, and over 12,000 deaths. Now, I chose to specialize in GI oncology, and unfortunately, the outcomes for many people with GI oncology is not as great in some of the areas. And for example, colon cancer is the fourth most common cancer, but it's the second leading cause of cancer-related deaths. Pancreas cancer, which you could see on here, is kind of down on the bottom in terms of incidence, but is the number 3 cause of cancer-related deaths in men and women. So it is a lot of what I do. It's not just having the best drug to treat the patient, of course, that's a no-brainer, but it's being able to care for our patients who get ill with our treatment and get ill because of the disease. And so we take care of the patient. It doesn't matter if they're getting chemotherapy, and many of our patients choose not to get chemotherapy. And that's where we need the help of some of our other services to care for these patients. Colorectal cancer, because it's what I do. We have a good news, bad news story. Good news, decreasing in incidence in older patients. Bad news, increasing in younger patients. And recently, recommendation was made to start screening patients at 45. I wouldn't be surprised in a few years if we say maybe it's 40. And in this slide, where the bigger figure here, this is the current situation. This is 2015 to 2019. As you get older, you're more likely to find you have a higher incidence of colon cancer within that population. If you take out the age from 50 to 59, you could see from 50, 51, and 52, the incidence in green is higher than in red, meaning compared to 1975 to 1979, the incidence is higher. In all the ages above that, the incidence is going down. There are probably a number of factors to explain that. It's probably related primarily to environmental factors to some degree. And we've noticed that it's people who were born around 1950 and after, that's where we're seeing a higher incidence in the younger population. So, prevention is also very important, not just treating the patients. And so we need to get the word out to have people screen, get their colonoscopies at an earlier age. Unfortunately, we're also diagnosing people at a later stage, and some of that could be due to the younger population. When people are young, they feel, okay, I can't get this cancer. You go to the primary care office, and they're not thinking about a 30-year-old having colon cancer because the incidence is so low. But we have to think about that because we are missing some of these patients. And so local disease, percentage of local disease is going down. Those with regional, meaning lymph node involvement, is going up, and metastatic or distant disease is also going up. So I'm happy to be part of the Mass General Cancer Center group or system. There are a number of hospitals that are part of the Mass General Cancer Center, and there are different kind of levels of affiliation. We're all connected in one way. But again, based on our subspecialty nature at Newton-Wellesley, our size, and the fact that we have extraordinary hospital where we can handle a whole lot in our center, we are part of what is called the Quad in our program. And that consists of the main hospital, Mass General, the Mass General Cancer Center in Danvers, and then the Mass General Cancer Center in Waltham, or MGH West, which is right off of 128. And so two of my colleagues who are part of our program are also medical directors at two of these other centers, in Danvers and in Waltham, and they both have clinics in our place. And both of them want to desperately hold on to their Newton-Wellesley clinics because they love being there. The academic mission, the teaching mission, it's a different feel in our office and in some of these other places. And the purpose of this, the great thing about being part of this quad and being part of the network, is that everybody in our clinic, all the docs, have to be connected with a specific disease group in Boston. So if you're a lung cancer doctor, you must be connected to the lung cancer team at MGH, attend all of their meetings, present patients there. And this way you get to know all the docs there, all the surgeons. And so, they send patients out this way, we send patients out there. The other good thing about this is that our colleagues at Waltham, oftentimes their cancer center, infusion center is crowded. They can't fit people in. Well, we say, come on over, send them over to Newton-Wellesley. What if we have a problem with our pharmacy, which has happened every once in a while? Things happen, refrigerators go down or something happens. Leaks. It's an old building. We get leaks with some frequency. So what happens is we then bring everybody together and we bring a meeting right away and we help divert people to other places. And so this has been incredibly helpful. We help MGH, they help us. And we're all friends and it works very well together. Oncology is like a team sport, as I was alluding to before, and that's why I love oncology and I love GI oncology, because I can't do what I do without the help of other great people. Diagnostic radiology cannot be overestimated. It is so, so important. When I was at MGH and I would see second opinions from all over the state or New England or over the country, so much of our difference in opinion was because we were able to review the scan with a high-quality radiologist who would pick out things. If I would see a pancreas cancer patient, I don't know how many they did in a community hospital in, I don't want to pick any state, but in a small community hospital, maybe they would see 10 pancreas cancers a year. Well, I'd have a clinic at MGH, and I would see in a typical afternoon 5 or 6 new pancreas cancers. And so when you're seeing that kind of volume and you're seeing all the unusual things, the radiologists pick up on things. So having diagnostic radiology that is high quality, and not only there, but there to look at the scans with us. And I put in a big plug because we almost were at risk of losing the radiologists that we have. We would still have radiologists, but we work so well with our radiologists from Mass General, and I'm going to fight to have those radiologists stay with us because they make us look good. Interventional radiology, those are the folks who put in the ports and do procedures, who work in George's vascular center. Pathologists, also critically important. If you have pathologists who are not good at making the diagnosis, you look bad and you're doing the wrong treatment for the patient. We have wonderful pathologists. One of our GI pathologists reads cases at Mass General. The chief of pathology reads cases at Brigham and Women's. So our folks are really connected to state-of-the-art diagnostics. Our hospitalists already mentioned, they're phenomenal. They communicate well with us. They take great care of our patients. Our patients from MGH, because we have a lot of overflow, they want to send patients to us. They just rave about the care that they get, and so then they don't want to go back into Boston. They don't want to wait in the ED, and then they don't want to be on the floors there. They really like it at Newton-Wellesley. Cardiology, yeah, I mean, George and I have been talking ever since I came here. I was talking to George. I think I bugged him when I first came here. I said, I need a cardio-oncologist. I have one at NWH. I want one here. And he's like, whoa, whoa, whoa. We could help take care of this. We'll work with our guys in Boston. We could do that. And the team there has been really great in helping us. And we've had some complications related to chemotherapy, which are rare, but they happen. And they've been great. And they work very well with the people who do only cardio-oncology in Boston, and so that the patients don't have to keep going back and forth. Gastroenterology, needless to say, Larry is an important ally, and we have great endoscopists, and we do a lot of really complex procedures at Newton-Wellesley, but there are some things that we can't do here, and our gastroenterologists know what they can and cannot do, and we then make a decision together. Okay, this patient should go in and get this advanced procedure. And part of it is that we want to make sure if there's a complication that we have the appropriate backup. We don't want to be left in trouble. But there's very little that we have to send into Boston for endoscopy. Of course, endocrinology, I do a lot of pancreas cancer. They have diabetes. They have all other kinds of issues. Infectious disease, pulmonary, dermatology, a lot of the new drugs, immunotherapies, they all have dermatologic toxicities. I send rashes, and it's great. I call any number of dermatologists, and I tell them I have this problem. They're like, send them over now. I almost never get told we have an appointment in 3 weeks from now. So that's great. Rheumatology, again, my immunotherapy drugs, they now cause all kinds of rheumatologic problems. And Bob Friday, who's the chief of rheumatology, is always great about getting these people in right away. And nutrition. And I'm sure I missed some here. Again, we can't do what we do well without having a hospital full of other resources. Multidisciplinary clinics. This is one of the things that is critically important and something that I learned as a fellow at Tufts. And Tufts was really good about having multidisciplinary clinics, meaning if you get a diagnosis, let's say of a colon cancer or rectal cancer, you will meet a medical oncologist, a radiation oncologist, and a colorectal surgeon at the exact same time. There are other big academic medical centers in Boston where you will meet the medical oncologist. You'll get an appointment the next day to meet the radiation oncologist, and then another day you'll meet the surgical oncologist. They may or may not have talked about you beforehand. In our clinics, in GI at least, and in the others, we sit together, we review the scans with a pathologist, with a radiologist, the whole team, the gastroenterologist, and we go in there already with a plan when we meet the patient. We've already looked through the chart. That's usually the medical oncologist who does that leg work, but we go in there together and we walk out all the questions answered, and patients love that. And that is something that's unique, that does not happen in many, or I think most, community practices. So what's my philosophy? Providers must be subspecialized and affiliated with the disease center at Mass General Cancer Center in Boston and attend subspecialty conferences. New patients should have access to the multidisciplinary care, which I really think makes a huge difference in the outcomes. All patients should have access to clinical trials. We're unable to have a huge portfolio of clinical trials, and I'll have another slide where I'll talk a little bit about that. But because of our collaboration with Mass General and because we attend all the conferences, we should be offering what we have in Boston to them and not say, well, we're just going to keep them at Newton-Wellesley. Many of them don't want to go into Boston, but we need to let them know what the options are, be perfectly, completely transparent. All patients with advanced cancer should have access to palliative care. When I first came, we had no palliative care in the outpatient. And I was starting to wonder whether or not I made the right decision to come out. I am so dependent on palliative care, so dependent. They are so important. Quality of life and just, I think even in survival, they make the patients live longer because of their interventions. And so fortunately now we have palliative care every single day in our clinic. And even if they're booked, if I have an urgent situation, they will come down. And I have many visits that I do together with the palliative care nurse practitioner or attending right there, 2 attendings in the room with the patient and the family, and it's very powerful. All patients should have access to behavioral health resources, social work. We have 2 social workers in the cancer center. Psychologists, we have our own clinical psychologist, and the PAC program, which is Parenting in Challenging Times. So a lot of our people are young, they have children, and even grandchildren can be affected by this diagnosis. And these are child psychologists who then speak to the parents or grandparents on how to communicate with their children. And provide academic medical center care in a warm community environment. That is important, and I think most of our patients feel that way. I think they do feel that they're getting a special kind of care, and they're feeling like we're on top of their situation. This is our team, and I left out people. I left out all of our nurse practitioners, so please don't tell them I left them out, because our APPs are phenomenal. But here we have the solid tumor folks, and half of these people are anchors at Newton-Wellesley, but we have Mass General oncologists who also come to supplement what we do. We have a head and neck oncologist who does a multidisciplinary clinic with head and neck surgeons and radiation oncologists. We have a melanoma. One of the melanoma folks comes out here, also does a multidisciplinary clinic. One of our lung cancer docs in town, who is a national authority on lung cancer and early detection, who comes out and does a clinic once a week at the cancer center. And we also have a neuro-oncologist who sees brain tumors and complications, neurologic complications of cancer and chemotherapy. And then we have our hematologic group that see either benign or malignant hematology, as I mentioned before. This is an area that we're trying to beef up. There's so much need for hematology, and there's so few hematologists out there, so we're actively trying to expand that. We have a bunch of surgeons we work with. We've got breast cancer surgeons. The breast cancer surgeons only do breast cancer. We have a hepatobiliary pancreas surgeon from Boston who comes and sees patients every Friday. He spends all morning, and sometimes it goes into the afternoon, and we all see patients together. On Thursday, we have colorectal multidisciplinary clinic. And so we have 2 colorectal surgeons that are phenomenal. I mean, word on the street has it at Boston, at MGH, you're somebody who wants to see the best person, you come out to Newton-Wellesley and get your surgery there. We have the state-of-the-art robots, and patients get the care. They get very, good attention from all of us. So I think I am so happy to have people. These are all good people. These are all people who are dedicated to the patients and also have a passion for research. So I really have a great team. I'm really lucky. We also have a neurosurgeon that comes out, not necessarily based, or you could see clinic. He does attend clinic, but it would be remotely. And we also have urologic surgeons, and we have a multidisciplinary GU cancer program with a medical oncologist, radiation oncologist, and surgeon. So, for all the major things, there are only like 1 or 2 areas that are very uncommon that we don't have, and that we would send people into Boston for that consultation. And if they want to then get the treatment at Newton-Wellesley, we would then potentially give them the treatment and work collaboratively with our colleagues. We've had a tremendous amount of growth in the cancer center. It's a very busy slide. We don't need to go over the details, but if you look at the bottom, the 5-year change, 111%. It's very clear we have grown. I think not only have we grown, and I think my colleagues could attest to the fact that we've also taken care of more complicated patients. There may have been a time where truly complicated patients were felt to be better managed in town, and it's very uncommon that we send patients into town to get treatment. I mean, obviously, we don't have an ego. If we think the best place for them to be is in Boston, absolutely. But most of the time, the patients don't want to go. They want to stay. And so you could also see in this graph here how we've increased to over 1,400 new cancer diagnoses. And it's not any one person. It's everybody. It's having the surgeons. It's having, medical oncology, radiation oncology. This is just showing that our volume for all of our cancer services is gradually increasing. There's ups and downs. And we do really well with our what's called a Net Promoter Score. So these are surveys that many of you probably have received at home after you come back from a visit, and you wonder, does anybody look at these things? Do they really care? We care tremendously about this. I get a report every week, and I look at it, and I'm looking at the trends, and I'm looking at the comments that people write. I look at every single one of them for our group, and we share a lot of the comments with the entire division. So we send an email out saying and if we see something that's not so good, we then talk to the people to whom those have been, that it's directed at. And this has been good for the people in our group to see when people say nice things. I think they feel good. It's a really hard job for the people who do the checkout and everywhere, infusion, to hear the positive feedback is really very nice. So what are our accomplishments? We've grown. And, my colleague Dave Ryan in Boston always says, you can't be stagnant. You always have to grow. And if you don't think about growing, you will fall behind. So I always want to expand what we offer and always want to increase. And so I think we've been very successful. Despite, there's been staffing challenges. I mean, COVID was difficult, and it is hard to retain certain kinds of support staff, but we're doing okay. We have excellent patient experience scores, integration of our providers with the NWH Cancer Center disease leaders, and most of them do feel like they're integrated into the Boston program. We've opened, Larry mentioned before, opened up a second linear accelerator so we could treat more patients. Beforehand, we had very old machine that kept breaking down. And so we've replaced that and added a new one. And not only can we treat more patients, we can now do some of the more complex treatments that take more time on the machine, something we called SBRT or radiosurgery. That's doing surgery with very focused radiation. Our people were certainly capable of doing it, but we couldn't take that much time off of the machine. Now we have two machines, so we could do a ton. Challenges. Clinical trials programs is at risk due to funding. Unfortunately, clinical trials is a money loser. Nobody makes money on clinical trials, but it is critically important to the mission. And when you have really good medical oncologists who are academically oriented and trying to advance the field, we love putting people on clinical trials. We want to contribute. And patients, I think, often like to participate in clinical trials. So we'll have to see, but when people ask me, well, where could we use help? One of the areas I say is clinical trials. And I'm really passionate about that. Increasing amount of effort devoted to prior authorizations and appeals. I think we're all feeling this in the system. Everything gets denied. You then have to appeal. It's lots of time on the phone. Half of the time it might be a misunderstanding. Oh, you should have said that in the first place. It's like, well, that's 5 phone calls later. And so it takes a lot of time. It takes time away from taking care of the patients. And I think that's about it. Happy to answer any questions. Thank you.
So one thing you learned tonight is that internists like to talk, but we do have a lot to say. We're detailed-oriented and academic, as we've said. You've learned that we love Newton-Wellesley Hospital. It's a great place to work. We think we provide great patient care, and it shows in some of the feedback that we get. But we have a lot of needs. We're in an aging building. Space is a major issue. Resources are constrained. These are difficult financial times. And we have big ideas. There's a lot more we think we can do for our patients and the community. So we do need your help. And I'd like to thank all the speakers.